So first of all, thank you for the organization, for the invitation. It's really my pleasure and an honor to be here with all of you in this wonderful meeting. Thank you, Vali, for your very nice presentation, especially Dr. Albert, because he has given me a great hand with his great lecture, giving me a lot of information before so I can go faster. First of all, what I want to show is my conflict of interest. My area of expertise in mechanical ventilation. I've been dedicated the last 14 years in training, teaching, and research around mechanical ventilation. I started always in pediatrics in both sides, just in anesthesia and intensive care in both sides. For this lecture, the only thing that I want to say is really, I don't want to disturb you, but I'm going to put you nervous. I want you to think, and think sometimes it's painful. It's painful because sometimes it requires change, and change the way we do things is quite complicated. If we apply some action in mechanical ventilation that I've heard from Russia up to Argentina or Chicago, that I have the opportunity to be there too, I heard all the same examples everywhere. Our colleagues say, I always ventilate at volume control, it works, why do I have to change? They say, okay, I'm not saying that volume control is good or is bad. The question is why we use always volume control. Why? What is the answer for that? I always ventilate without PEEP. PEEP is hemodynamically dangerous, especially in pediatrics, neonates. Wow, PEEP is very dangerous. Why do I have to use it? I always said a relation, I really like this one. IE relation 1-2, because it's the most physiological. What is the IE relation we have when you are sleeping during the night? During the night, I hope you are sleeping, not other moment. If you are sleeping, what is the IE relation we usually use? Figure. 1 to 4, 1 to 5, and that is not physiological. No? Another thing, neonates. What is the normal physiological IE relation?
1 to 1 or 1.5.
And that is not physiological. Another thing is, imagine during the night you are making some exercise or you are running after the bus. So what is your normal IE relation? Up to 1:1. And that is not physiological to make exercise. So, but if we program the ventilator, we always set the green points, and the green points say is 1, 2. So sometimes, and I think really I think in mechanical ventilation this is really true. For keeping learning, sometimes it's indispensable to unlearn what you know now. It's painful, but it's necessary. This is a very nice study to make us think. There's no answer to this paper. It's up to 27,000 patients obtaining the data from almost 85 blood sample, and all this data is not manually recorded, it's computer recorded. During 5 years, excluding complicated cases like cardiac or thoracic procedures. So this is all daily routine cases. And what anesthesiologists do against hypoxia. I think hypoxia is something quite important, especially if you stay more than 3 minutes, for neuro. So what the anesthesiologists do when you have against a PF ratio of, this is normal, no hypoxia, moderate hypoxia, severe and extremely severe hypoxia, PF ratio less than 100. In some cases, you put it directly into ECMO. And let's see what the anesthesiologists do inside the operating room with PEEP, with VO2, with maximum pressure, and with tidal volume. Okay, first thing, tidal volume, milliliters per kilo, predicted body weight. There are questions how many of us, correct, or set the tidal volume with the predicted body weight. And of course, with normal people, 10 per kilo. Obviously, 10 per kilo, always 10 per kilo. It's a very nice figure. But I don't say this is good or bad. What I really want to ask is, why the hell someone is giving more than 15? Maybe exactly the same reason that why we have to use less than 5. in normal healthy patients. But what you really have to make us think is what we do in a very severe distress syndrome. There is severe distress syndrome, still are people giving 15 milliliters per kilo. So what's happening with PEEP? Okay, so normal people, I don't say that we have to use, or yes, or maybe I'd say, but I don't want to say that this is the figure for normal people, for hypoxic people. What I'm saying here is that normal people, some of our colleagues give only 2, never use 2. You always say 0 or 5. No, that's the way we do it. But some of them using 17 or more than 15 in normal, healthy people. So, but what's happening in distress? In distress, still now, there are some of our colleagues that still not use PEEP or a maximum of 5 of PEEP for a very severe, extremely hypoxic distress. So what we do with maximum respiratory pressure? We all know that if we, as much pressure we give, we destroy more lungs. No? So, okay, if I give a huge amount of tidal volume in a distress syndrome, what are the results? 15 of maximum pressure. So, of course, you saturate the patient, but you destroy the lungs. So what's happened with VO2? That is everything. This is the only thing that we all agree. If the patient has hypoxia, 100 for everybody. I'm not saying that in an acute hypoxic event, you have to increase VO2. I don't say that. But maybe we can do something else. And especially, can someone explain to me why the hell in a normal healthy patient we are using 100 of VO2? Because someone left VO2 no, from the last cases. No? So something changed from the beginning of the surgery up to the end of the surgery, because we have 2 or 3 hours no, to do something with the machine. No? So maybe we can play, no? We can change something. No, of course. We said at the beginning 10 per kilo, 0 PEEP, 100 of VO2, and it's nothing changed from the beginning to the end. But have changed something in the last 5 years. 5 years, there are a huge amount of research, clinical research, at least, I don't say in PEEP that there are, but at least in reduction in tidal volume, not at all. In 2005, 9 and 9, nothing has changed. So really, I think there is a huge work ahead of us in training, that because really, if I make some question like, do have to reduce tidal volume to reduce the stress? I'm sure all of you are going to say yes. Okay, but then when you are starting to ventilate a patient, why are you going to do it? So nowadays we all increase the VO2, but so far it's quite difficult to change things inside the operating room. So we decided, our training group, to change it. The best way to change something is if you visualize. If I give you a video of 30 seconds that explain the formula, how to do things, you remind this image for the rest of your life, and then you can change it, more than with through a paper. So we propose a physiological, a visual approach to mechanical ventilation. First, sorry, because in 30 minutes I don't have time to sum up 12 years of that, but some ideas. For example, how many of you program PEEP routinely in every single case of neonates or preterm babies? Wow, good. I said that because I don't want to, the rest of the people, because now they are going to see something. I perfectly still remember it was quite difficult to convince our colleagues with some age to use routinely PEEP in pediatrics, in neo or in preterm babies. So this was our first research. The first thing that we try to do is to work with isolated lungs. If I can see the lungs directly, I can extract the lungs of the piglets and see how it works. So what we want to show to you here are the main difference between adult lungs and neonates lungs, healthy in both cases. So we ventilate these lungs with the same ventilator, and what I want you to focus is the time that neonate requires to collapse. If you disconnect a patient, it's collapsed, and this one is still going, and the adult lungs never fully collapse. It's much more stable. If you touch it, there is air inside. But if you touch a neonate lungs, it's like liver. There's no air inside. And in only one expiratory time, 0.4 seconds. So atelectasis is something, is expiratory period, and it's instantaneously. Maybe you have heard, have read that in many books, like neonates have a functional residual capacity who is less than closing volume. So we all know that. Let's see what really this means. If the volume, closing volume is the minimum volume you need to keep the lungs open, and the functional residual capacity is not, because it's an expiratory lung volume that Vali taught us, but functional residual capacity is the volume you remain inside of your lungs when all the elastic forces are in equilibrium. So if your volume that you have at the end of expiration is less than the you need to keep the lungs open, what's happening with neonate? Open, collapse, open, collapse. Now, in each breath. Do you think this can be possible? There should be something. There should be something to solve the situation. Do you know how much pressure a neonate, the first time he breathes, you know, from the fully, what is the most fully collapsed in the world? The ones who never receive air. So when you go out from your mom, you try to make your first respiratory effort. You know how much pressure do you need to do to open the lungs? 70, 60, 70 is measured in lumps. Do you really think a neonate can afford to generate this kind of pressure? You know, open, close, 60 of pressure. There should be something there. What is there is this glottic closure reflex. The first time is like that, but after you open it, they close the glottic before the end of expiration. They increase end lung volume, end expiratory lung volume, and this is PEEP. We volume with PEEP. Without PEEP, we don't exist. So imagine something that is absolutely physiological to convince to your colleagues that you have to program PEEP in every single patient. So this is our approach. I think we have to go in the physiological approach for neonates. Compliance. What I want to sum up in these three next slides, why a preterm baby or neonate is so difficult to ventilate. Why all our life we've been doing in TPs and spontaneous breathing? Why we had so many problems in the past trying to do mechanical ventilation? Here will be the answer. It's the toughest lung. You know, the worst adult lungs condition, the dynamic compliance is around 15-10. 10 is die. Around 15 is the worst lung you can ventilate in adults. Do you know what is the normal compliance of a healthy neonate? 1 per kilo. So 3.5 kilos is 3.5 of dynamic compliance. It's 5 up to 8 times harder, stiffer than the adults. That's why it's so difficult for a machine to ventilate in neonates. But we have to know this in advance, because now you are ventilating a healthy 10-kilo baby, and the machine is showing you 5 of dynamic compliance. What is the problem with this patient? 10, what is the theoretical dynamic compliance? 10, no? If the machine is giving you the information of 5, what is you don't have to do anything, you know it. What is the problem? Selected intubation, no? Something that gives you just the half, no? But if you, other figure, you have 10 and the machine is giving you 8. Do you think it's normal? Something is happening. Maybe this patient is having atelectasis, as Professor Bali have explained to us. So please check dynamic compliance. It's in some machine is second screen, so it's to push the button. It's not very tough. So check this one because it's going to give you a lot of information. Resistance, airway resistance. This is the other crucial difference in neonate and small children compared with adults or older children. Up to 2 years old, airway resistance is huge. Neonate or preterm babies can reach more than 100. Do you know what is our resistance now? I hope all of you are reading. What is your normal airway resistance? Is there? Around 10. So neonates have 10 times more airway resistance. It's like ventilate a bronchospasm in adult. So it's very hard, very tough lungs with a huge amount of resistance. It's like ventilate bronchospasms in adults. That's why it's so difficult to ventilate this kind of patient. So to sum up all the most important figures that we have to keep in mind, clinically speaking, about when it is time we ventilate a neonate or preterm baby, is neonatal lungs, they are prone to collapse. All of them have atelectasis during anesthesia. All of them, don't have any doubt about that. That's why it's the best model for recruitment maneuvers and everything that you can prevent atelectasis. Low pulmonary compliance is very the same, like a good model to ventilate distress syndrome in adults. Higher wave resistance, like a bronchospasm. So neonate, it's very, very important. It's time you want to ventilate someone safely, ask if this machine can be perfectly well delivered for preterm babies. Then they will use it for the rest of the patient. That's as simple as that. Okay, let's move. Nowadays it's changing. A new concept now in these 2 last years. We've been talking about protective ventilation. But protective ventilation is associated in most of the cases in the critical care environment about the distress syndrome. Everybody's talking about distress syndrome, and how to protect the distress syndrome. And what happened with the rest? We are using mechanical ventilation in every single patient. It's important how we program the machine in every single patient. We don't know, it's a question. What we think today is optimal ventilation or best practice is every time you are going to program or you are going to set mechanical ventilation, you can do it with the less pressure as possible. The objective is clear. I want to deliver the oxygen you need. I want to remove the CO2 in a physiological range, but with the less pressure as possible. We know that this is the bad part of the job. And maybe reduce pressure for 18 up to 15 or between 15 up to 10 is good for the lungs. Let's see. And protective ventilation clearly is for distress syndrome and intensive care area. So let's go to analyze these 3 parameters. How many of you think like plateau pressure is what we have to control? Plateau pressure or maximum pressure? Nobody? You think it's important to reduce it? Yeah, okay. Do you think the solution to protective ventilation or optimal ventilation is the amount of PEEP? Everybody is always asking you, say, what is the PEEP I have to use in neonate? What is the PEEP, like a recipe, no? What is the PEEP for cardiovascular? What is the PEEP for obese patient? What is the PEEP for laparoscopic? Do you think really this is the approach? The amount of PEEP? How many of you routinely use PEEP, for example, in a laparoscopic procedure? Okay. What is the figure you use? 5? How many of you use 5? 5? 10? So they say it's not the amount, but when I say 5, you say 5. So it's the amount, except some of them. So the concept is the amount, you say no. But when I say 5, you say yes, 5. So it's not the amount, but you use it through amount. So, and do you think that now everything is solved with 6 milliliters per kilo for tidal volume? Let's see. It seems like that. This is a very nice study, and in my opinion, this is crucial to have this in mind. Healthy lungs, absolutely healthy lungs under anesthesia. This is rats. So if you give a driving pressure, driving pressure is the difference between the maximum pressure and PEEP of 35 centimeter water, only in 20 minutes, you create a distress syndrome. If you analyze these lungs, it's exactly the same like a distress syndrome. So obviously, how you ventilate a normal healthy lung can change totally the characteristics of the lungs, and you damage the lungs. But this is rats, no? So rats, it's not important rat. This is, it seems like it's not rats, no? It seems like a human beings. Do you think this is a heart? It seems like a patient, no? This is a very nice study of 12 patients, real patients, doing by radiologists that say, oh, here's something curious. because all of these patients are lobectomy. So what the anesthesiologist said about, after the postoperatory period, if you have a pneumonia or you have a distress, is due to the surgeon, because they are touching, and cutting, and whatever. But there is one interesting thing. The operating side was this one, and the healthy one was this one. So this one, the one that it was healthy before ventilate through the net with anesthesiologist. So this is the healthy lung ventilated with a huge amount of tidal and pressure. So he record that the distress and the destroyed side, it was not the operating one. It was the one that the anesthesiologist has been ventilated. So now we all know that every time you turn on a ventilator, please think you are using a powerful tool but can destroy the lungs of your patient. Really, let's go further, because really we don't have too much time. This is a classical approach of Gattinoni about what is ventilatory-induced lung injury. He's always focused on barotrauma. Of course, we know that transpulmonary pressure is the key point, but how do you know it? Transpulmonary pressure, you have to measure pleural pressure, and we don't have it. We try to do it with esophagus pressure, but it is mixed, it's a mistake in more than 60% of the cases. So clinically speaking, it's impossible at the bed or inside the operative room really to know transpulmonary pressure. And volutrauma is quite strained, it's quite tricky, because how do we know functional residual capacity? Now maybe in the future we can make some approach, but not the real functional residual capacity. So about the ones who thinks like to limit plateau pressure is the solution, this is a very old approach. Now we know that permissive atelectasis, that is, I'm going to limit the maximum pressure and that's all. What is the problem about this approach? Of course, for the atelectasis area, you are not going to damage. But what happened with the rest? The physiological concept is very clear. Imagine we are the alveoli of one lung, okay? This is the back part and this is the upper part. The back part, the atelectasis is always in the back part, okay? Imagine the last four lines are fully collapsed and I am the ventilator, okay? So I'm giving 10 per kilo, 100%. So do you think I'm going to deliver pressure to the back part? But what happened with the upper part? Overdistended. They have to work. I always explain that in a service. If in one service, if you're chairman of the department, if in one day 10 people don't go to work, what happened with the rest? They have to do the work of the other one. So if you go through the way of permissive atelectasis, you are not going to destroy the lazy ones. You are going to destroy the healthy ones. So it's even worse. So forget this concept, because it's not nobody support that anymore. Sorry, I would really like to get into that. If someone wants to make this question at the end, it will be great, but I don't have to do that. So everything is solved through the amount of PEEP. I only give you something to think about it. This is New England Journal. Nobody can say anything about this paper. So, wow, New England. And some of them say high versus low. This is quite tricky. What is high for you and what is low for you? If you ask someone, high is 10, for other one is 5. So, but let's continue. In this paper is saying high PEEP is worse than low PEEP. Okay, 6 months later, the same paper, the same journal, New England, is saying just the opposite. No, we have to stop the study because high PEEP reduced mortality in 15%. So they had to stop the study because it was much better to use high PEEP. If someone can give me the answer, I will appreciate that. But it's even more confused. I always try to read the papers against recruit maneuver, against protective ventilation, just in the way you say what they are saying and try to see what you think is the reality. So I was really shocked when I read this paper saying, okay, low tidal volume, 6 meters per kilo, plus high positive and expiratory, you know what is high? 10 is the worst you can do. It's much better, 10 per kilo and no PEEP. So we can think about it at the end. So let's go to that, because I think this is very, very nice approach. Because now everybody's talking about 6 meters per kilo and everything is solved. Every time I see someone talking about this, I always make this question. And they never forget me, I think they hate me. If I were a ventilator, imagine physically, if I were a ventilator and someone programmed me with let's say 6 meters per kilo, and I have to ventilate all of your lungs simultaneously, and I have the opportunity to measure the pressure you're giving me back, it will be the same amount. And ventilator, all of you, and I know the pressure you are giving me back is the same pressure. Why the hell we have to give 6 meters per everybody? Can someone explain that to me? Very nice study. I highly recommend to read it. I know that it's experimental, because this is a cell culture of alveoli. And maybe you can do, let's culture cells. I don't want to get into that. It's a very nice study. They can stress the cells in a different way. So they create a mechanical situation that they can give CPAP. And what they measure, if the cells die or not. So they get alveoli, the culture, and they stress it with different type of pressure. And the conclusion is very, very nice. CPAP or PEEP, it doesn't hurt that much. It doesn't kill the cells. Between the rate, the respiratory rate, it's not important. That what is really important is the amplitude. So if the amplitude between the rate, this one can be a lot of rate, but the amplitude is exactly the same. This is what is really tricky. And the most important and very nice finding is this one. What is really important, between this one and this one, the amplitude seems equal. But if you put if you put PEEP and reduce the cyclic exactly with the same maximum amplitude, but you reduce the cyclic stress, you reduce the mortality of the cells. So that's, and this is in advance, it's a gift from Amato, that is now coming in New England. What he has made is to reevaluate all the RSNet studies, and what he really has shown, this difference between high PEEP, low PEEP, and what is the difference is driving pressure. So really, what really makes the difference, if you control the difference between the maximum and the minimum pressure, I always like to explain that, but I need a volunteer, but no, I don't have that much time, but please keep this in mind. If I want to, no, with a lady, no. If I want to slap someone, I need a volunteer. Slap, sorry, you are strong. So I can do two things. One, I have to approach. So first of all, I can do like that. Wow, no? Or I can do like this. Which one do you prefer? The second one. This mechanical stretching is in inertia. If I come in from 0, no PEEP, 0, no PEEP, you know, it's the maximum pressure. I come in from 20 of PEEP up to 30, it's only stretching of 10. So what is really important is the cyclic stretching. Let's continue. So this is the approach. Let's go faster. Driving pressure is what we have to focus on. Really, we don't know the figure. The first time is Amato, but it's for adults. It's 15. We have to, and now is what I'm trying to do, we have to know in pediatrics, for sure, for neonate and preterms, it should be something around 10. It cannot be 15. And we have to focus in the future on that. Okay, just to visualize this concept. In both cases, it's a huge amount of stress, but in both cases, the maximum pressure was 30. In this one, it's only 5 of PEEP, and then it's in 10 of PEEP. Traditionally, these studies say, wow, 10 of PEEP is bad. See what's happening in the alveoli. It's not moving. Okay. What I really want you to focus is like, during the expiratory period, these two ones is collapsed. And in the expiratory periods, they open. But this one, for me, is not important. What is really, watch this one. Compare with this one. The problem, each time I have to reopen the collapse area, I over-distended the ones who has been open before. And this is what really destroyed the lungs. If I set more PEEP, is to avoid over-distend the ones who are working. Okay, so this is now what we think about tidal volume versus driving pressure. Of course, we reduce tidal volume, but not with a magic figure. What we have to watch out, or we have to focus, is in driving pressure. If the patient has a very elastic lungs, maybe you can give to a 10, 12, that's not a problem. The driving pressure is very small, no problem. But you have to reduce tidal volume to reduce driving pressure. Really, I would like to get into that, is recruit maneuvers and how to reopen that. Only some slides to remember this. For the ones who really still don't think that we create atelectasis, this is dedicated for you. This is a 3 kilo healthy rabbit before anesthesia. This, what you are seeing here, is nothing, is air, is the negative airway of the rabbit before, in spontaneous breathing, before the induction of anesthesia. Just after induction of anesthesia, you see? Instantaneously. So let's go, because I don't want you to disturb with this. We can get into that after the, okay. Okay, only to show you one thing that I really, this is a study, is being published in European journal, that what I really want to show here is how dangerous, or it's dangerous to perform recruit maneuvers in neonates. What is the two fears we have when we are performing recruit maneuvers? First of all, how many of you perform recruit maneuvers in pediatrics, neonate pediatrics, routinely? Great, great, things is changing. The two fears are, one of them, to create barotrauma, it's there, and hemodynamic repercussion. So this was to study what is the level to start to create pneumothorax, and what is the minimum pressure we need to reopen the lungs of a neonate. So we study in two different ways, keeping the driving pressure constant all the time, or with a different driving pressure. I want you to see this one, because this is the way that traditionally we've been ventilate all our neonates. This is rabbits. We perform an stenotomy, an open stenotomy, and what we see is what's happened if we don't use PEEP at the beginning. This is the way that we've been ventilate our lungs all our life without PEEP. During the expiratory period, see how many areas you get collapsed, even macroscopically. And during the inspiratory period, you reopen it. Saturation 100. But you are destroying lungs. So what we did here, we filled with saline, and we increased pressure up to the pneumothorax area. The results here, let's go, is like we never create any barotrauma less than 50 centimeter water. And the pressure you need to reopen the lungs of a neonate is something between 25 and 30. So you have almost 25, 30 centimeters of water of safety range. So there's no fear about to create pneumothorax. If you reach 25, 30, we recommend 30, 15 as a recruit maneuver. You have more than 20 centimeters of water of safety range, not create any pneumothorax. The next thing we conclude is that what is really dangerous for pneumothorax is obviously the maximum inspiratory pressure, but the driving pressure, not the PEEP. If you increase the PEEP according with the maximum pressure, you have safetier ranges to create pneumothorax. This is other model, just as conclusion. This is to see the hemodynamic impairment. And this is peakless and real neonate, less than 24 hours of life. So it's a real neonatal model. And we measure cardiac output, invasive blood pressure, cardiac output. And as you can see here, if you give fluids 10 meters per kilo before the recruit maneuver, and the patient is stable, you are not going to find out any kind of repercussion. What neonatal did is to increase the cardiac rate. So they increased the cardiac rate during the maximum, and this is like experimental. We reached 35 of maximum pressure and 20 of PEEP. That is not necessary, 30, 15. Okay, and to summarize everything, I mean, nowadays we think protective ventilation is a big puzzle. And if you really want to see the good picture, you have to put all the pieces together. It's not a question to recruit maneuver. It's not a question, it's a question to put all the things together. So recruit maneuvers, especially in pediatrics, are crucial. Tidal volume, but to reduce driving pressure, otherwise it's not necessary. No disconnection. This is physiological programming. If someone wants to ask about this, it's very nice. We are starting a clinical study that instead of to fix an IE relation fixed. If you modify it, you change the maximum pressure in 4 points. And be careful with VO2, abdominal pressure, induced hypothermia, and mechanical assistant devices. Okay, and this is our conclusion. Thank you so much for your time, and it's been a pleasure. Thank you.